nasal sinus disease. And starting first by the technique of examination, we have two main examination types for the paranasal sinuses. The first one is known as the routine study, and this is performed by putting the patient in the prone position, and we have the scanogram like this one, and we identify the area to be scanned from the posterior wall of the sphenoid sinus, and we proceed anteriorly until we reach an anterior wall of the frontal sinus, and this scan interval is about 3 to 5 millimeter in seconds. Then we have the full study, which include an axial sections, putting the patient in the supine position, starting from the region of the hard palate, and you proceed superiorly until we finish the frontal sinus. Then we have the coronal scans, and we also have the brain scans as well. And in this full study, we usually need to inject the contrast material. While in the routine study, we do not usually need to inject the contrast material. In the routine study, we usually have the bone window images only, but in the full study, we should have the bone window and the soft tissue window images. And as you can see here, this is the difference between the bone window images, where you can see only the details of the bone as well as air-containing structures, while in the soft tissue window, you can also see the brain parenchyma, the soft tissues of the orbit, as well as inside the paranasal sinuses, if there is any soft tissue masses or secretions. Then we may use the facilities of the recent machines to perform this type of imaging, which is known as 3D imaging, and you can see that this is very helpful and essential, especially in cases of maxillofacial trauma. Then we are going to have some anatomic details. Then we'll proceed with diseases, including sinusitis, the retention cysts, some mucoceles. Then we finish by the neoplasms of the paranasal sinus. Starting first by the anatomy, we proceed by the axial images, and we start from the level of the hard palate, and we can see the root of the maxillary sinus. And going up, we can see the maxillary sinus on both sides. And here you can see the maxillary sinus, and this is the pterygoid blades, as you all know. Inside the nasal cavity, you can see the bony nasal septum, and on either side you can see the nasal conch. Then going more up, then you can see this is the maxillary sinus on the left, and this is on the right. This is the nasal septum, and this is the nasal conch. This is the nasopharynx. More up, you can see the nasal bones and the maxillary sinuses on both sides. Then you finish the examination by reaching the frontal sinus, as you can see in this image. Here you can see between the orbits the ethmoidal air cells as well as the sphenoidal sinus as well. Then in the coronal images, you can see we start from the posterior aspect of the sphenoid sinus and proceed anteriorly. Then here you can see the posterior aspect of the sphenoid sinus. Going more anteriorly, you can see two parts of the sphenoid sinus divided by this septum, and underneath the sinus you can see the nasopharynx. Then more anteriorly, this is the sphenoid sinus, and this is the nasal fossa. And you can see the inferior turbinate as well as the middle turbinate. Here is the most posterior part of the maxillary sinus. Then proceeding more forward, you can see the maxillary sinus on both sides. You can see the nasal turbinates, you can see the ethmoidal air cells between the orbital cavities, and here you can see the hard palate. Then more anteriorly, you reach the region of the frontal sinus on both sides, and this is the crista galli, and here is the bony nasal septum, and on both sides you can see the ethmoidal air cells. And we finish by reaching the frontal sinus, and here you can see this is the frontal sinus, and also the most anterior part of the maxillary artery. Then we came to some more details about the anatomy, and here you can see what's known as the osteomeatal unit. And by the osteomeatal unit, you will know that it is the complex including the maxillary sinus ostium, the infundibulum, the ethmoid infundibulum, the hiatus semilunaris, and the ending by the middle nasal fossa. And here you can see in the floor of the orbit this important foramen, which is known as the infraorbital canal. And these arrows point to the pathway of the osteomeatal unit, where you can see the site or the possible site of the maxillary antrum, ostium, and the ethmoidal infundibulum. This is the hiatus semilunaris, and here the middle nasal fossa. Then here you can see this is the maxillary sinus on both sides, and this is the osteomeatal complex, and this particular image will show the region of the ethmoid infundibulum, which is the passage between the site of the ostium and the hiatus semilunaris, as you all know, bordered medially by the uncinate process and laterally by the orbital wall. Then the ethmoidal complex is formed of three major parts: the horizontal part, which is the famous one known as the cribriform plate of ethmoids, and the vertical part, which is the crista galli, and the ethmoidal air cells, which are located on either side medial to the orbits. Then above the cribriform plate of ethmoid, you can see the region of the gyrus rectus as well as the olfactory bulb. Then the ethmoidal air cells are composed of two major groups: the anterior group, which are smaller and more numerous, while the posterior group are relatively larger and fewer in number. Then the most large, or the largest ethmoidal air cells, which is located posteriorly near to the orbital canal or the optic nerve canal, is known as the Onodi cell, as you all know. And this is one of the important cells, also is known as the Heller cell, which is the pneumatization or extension of the pneumatization into the orbital floor, intimately related to the ethmoid infundibulum, and it may encroach significantly on the osteomeatal unit, as you can see. Also, you know the ethmoid bulla or the bulla ethmoidalis, which is the largest ethmoidal air cell constantly present near the osteomeatal complex, and this is its anatomic location. And here you can see this is the region of the ethmoid bulla. Then few words about the frontal sinus, which is best seen in the coronal as well as in the sagittal images. And this blue line, the yellow line, represents the area or the route of drainage of this sinus through the anterior ethmoidal air cells into the nasal cavity. The intestinoid sinus is located within the sphenoid bone, and it is usually present at birth, and you can see its intimate relation to the nasopharynx as well as to the floor of the cella above. Then this is the appearance of the sphenoid sinus in different images: in the coronal image, in the axial image, and in the sagittal reconstructed image. You can see this is the sphenoid sinus above the cella, this is the cella above, and the nasopharynx below. And this is the passage of the drainage of the sinus through the posterior nasal cavity, posterior to the superior nasal turbinate. These are the nasal turbinates. This is the inferior one, and this is the middle one, which is pneumatized, and this is the superior one. And here you can see beautifully the way of drainage of this sinus. Then some of the normal variants you can easily see in the scans, including the commonly seen deviated bony nasal septum, and sometimes we can see pneumatization of the bony nasal septum, as you can see here. And also you may see what's known as the nasal septum spur, and this is a bony ridge which is arising from the lateral aspect of the bony nasal septum. Then one of the common variants is the concabulosa, and is commonly affecting the middle turbinate. And this is the normal turbinate, so you can see, and here is bilateral asymmetrical concabulosa. And this is another case of concabulosa showing a pneumatization of the middle turbinates being more larger on the right side. And this is an infected concabulosa on the right side. You can see the concabulosa is obliterated by secretions. And actually, you know that still the frontal or the X-rays of the paranasal sinus should have a role in the diagnostic battery of the paranasal sinus disease. But actually, this role has been declined very much in the recent years because of the availability of other imaging modalities, particularly the CT and the MRI. Then the paranasal sinus radiographs are still used for screening of patients for sinusitis, looking for the effects of trauma on the maxillofacial area, and also in the preoperative planning and some cases of dental disease. But in order to be sure about the sinus disease, we should have this routine study, which is performed in the coronal scans, and we are sure that the sinus is containing some of these secretions. Then here are the radiographic findings, the findings that can be seen in the plain X-ray considering the paranasal sinus disease. Number one, you may see mucosal thickening, you may see air fluid level like this one, and you may see total opacification of the sinus, bone erosion, bone destruction, bone sclerosis, intrasinus calcification, and sometimes you see foreign body fractures. Then starting by the diseases affecting the paranasal sinuses, the most famous one is the sinusitis, and sinusitis are usually diagnosed using this routine study by CT by identifying opacities in the paranasal sinuses. And we can differentiate between acute sinusitis and chronic sinusitis, first by the clinical history, and second by the appearance of the opacities in the sinuses. If we have air fluid levels, we assume that we are dealing with acute sinusitis, but if we have concentric mucosal thickening, we assume that we are dealing with chronic sinusitis. Then one of the sites of the important sites for mucosal thickening is the region of the osteomeatal complex. And you can see here, in spite of the presence of some mucosal thickening, the sinus is still clear because the rest of the osteomeatal unit is still patent. And chronic sinusitis are diagnosed by the presence of concentric mucosal thickening and also by evident bone sclerosis of the affected paranasal sinuses, as you can see here, and this chronic sinusitis affecting the left side of the sphenoid sinus. And this is another case of chronic sinusitis with concentric mucosal thickening of both maxillary antra, as seen in the axial images as well as in the coronal images. Then the silent sinus syndrome is the syndrome which is resulting from chronic occlusion of the maxillary sinus and gradual absorption of air from the sinus, resulting in a small, partially or totally opaque maxillary antrum. And you can see this is the normal antrum, which is lumetized, and this is the small sinus on the contralateral side. And this is another example of silent sinus syndrome affecting the right maxillary antrum, which is opaque and smaller than the left one, which is normal. Then retention cysts are the result usually from accumulation of fluids in the submucosa lining the paranasal sinuses, and you can see this characteristic one. These retention cysts are more famous and more common than polyps in the maxillary sinuses. And if we have this appearance in the paranasal sinuses, it's well known for all of you, which indicates the presence of sinonasal bulbosus type. And you can see here that most of the paranasal sinuses are obliterated by mucosal thickening. Some of the sinuses are expanded, the ostium is also dilated, and you may get some bone erosions in the course of the disease. Then this is another case of sinonasal bulbosus type showing total opacification of the ethmoidal air cells, maxillary antra, as well as soft tissue masses filling the nasal fossa, emerging with the nasal turbinates, diagnostic of nasal polyps. Then here is another case in the axial images, and you can see obliteration of the maxillary antra, ethmoidal air cells on both sides, and some of the disease is seen filling the left nasal fossa. In order to differentiate between nasal polyps, which are less common compared to retention cysts, and the only discriminative way is to identify another lesion in the nasal cavity. And if you see a lesion like this in the maxillary sinus or in the sphenoid sinus, you call it retention cyst. But if you see another lesion in the nasal fossa, you should correlate both lesions together and reach the diagnosis of polyps. Then some of the literature say that MRI can have a role in discriminating between polyps and retention cysts, but actually this is not well tested in the clinical practice. Then we came to the antroconal polyp, which is a lesion arising from the maxillary antrum and extending through the original ostium or the accessory ostium into the nasal fossa and maybe into the nasopharynx. And some of the important findings of this particular pathology: number one is the expansion of the affected antrum. Number two, dilatation of its osteomeatal complex. Number three, the clear ethmoidal air cells on the same side of the lesion. Then you can see here an antroconal polyp involving the left maxillary sinus, protruding into the nasal fossa, merging with the nasal turbinate, and the remaining part of the lesion is seen in the posterior part of the nasal cavity. And here you can see an antroconal polyp protruding from the sinus through one of the axillary ostia of the sinus into the nasopharynx. Then, considering the mucocele will result from obstruction of the drainage of the sinuses, resulting in the retention of the secretions and expansion of the affected sinus. And actually, the plain X-ray may have a role, but the CT is the most reliable diagnostic way. And here you can see an example of maxillary anteromucocele. The sinus is expanded, the wall is thin, and the sinus is totally obliterated by secretions. Then we came to the particular issue of sinusitis, which is the fungal sinusitis. And for the diagnosis of fungal sinusitis, you should look to the secretions inside the sinus, which are relatively hyperdense or appear bright compared to the secretions of the regular sinusitis. Look at the secretions of regular sinusitis, they appear relatively of fluid density, they are black. But the secretions relative to the fungus are usually dense because of the presence of some pigments and other components which give hyperdensity to the fungus component inside the sinus. We have three types of fungal sinusitis: the allergic type, the fungal ball, and the invasive fungal sinusitis. The allergic type is usually seen in immune-competent patients, maybe in children more common, and the presence of hyperdensities is very important for diagnosis of fungal sinusitis. Then compare between the density of regular sinusitis and the density of the fungal sinusitis. Whenever you see calcium inside the fungus, then you are in the diagnosis of a fungal ball. Then if you look for this case, and you can see only sinonasal bulbosus type. But if you look to the soft tissue window of the same case, you can identify that part of these lesions inside the antra are retaining the hyperdensity of the fungus. Then this is a sinonasal bulbosus type, which has been complicated by superimposed fungal sinusitis. This is the regular sinusitis, and this is the fungus, which is relatively hyperdense. And whenever you see fungal sinusitis that is eroding bone, then you know that you are dealing with an invasive fungal type, fungal sinusitis, which is usually seen in immune-compromised patients. And this is another example of sinonasal bulbosus type complicated by fungus. You see the hyperdensity of the fungus in the soft tissue window, and you can see the erosion and the destructive changes in the floor of the sphenoidal sinus. One of the important issues to spot the diagnosis of fungus is to have the MRI T2 weighted image, because fungus is very dark in the MRI T2 weighted image, while the regular sinusitis will have the fluid signal, which is very bright in the almost similar to the CSF or any other fluid. But particularly the fungus will appear very dark in the T2 weighted image MR. Then these are the features suggestive of fungal sinusitis on imaging. Number one, you detect hyperdensities within the affected sinuses by CT. Number two, you can see intrasinus calcification. Number three, you can see very dark signal on T2 weighted MR images. Number four, sinusitis which is refractory to medical treatment. Number five, maxillary sinusitis which is extending to the cheek. These are the helpful criteria to suspect the fungus etiology of sinusitis. Then too many complications may result from sinusitis, intracranial and intraorbital. Intracranial, we may have meningitis, we may have epidural, subdural, or intracerebral abscesses. This is an example of frontal lobe abscess secondary to sinusitis, and this is a localized meningitis with epidural emboyema in the occipital region. And sinusitis of the ethmoidal air cells may have an access to the orbital cavity, resulting in too many complications like preseptal and orbital cellulitis, supraostial abscesses, and maybe cavernous sinus thrombosis. And in this case, you can see the degree of sinusitis on both sides, and you can compare this orbit compared to this one. You see most of the muscles are enlarged and appear enhanced with contrast material. And this is another case of ethmoidal sinusitis complicated by orbital cellulitis and supraostial abscess medial to the medial rectus muscle. Finally, we came to the tumors affecting the paranasal sinuses, starting by the benign ones. And one of the most common benign lesions affecting the paranasal sinuses are osteomas. And these are the ivory osteoma with no cancellous bone inside. And this is another an example of osteoma in the posterior ethmoidal region. And this is a classic osteoma within the frontal sinus on the left side. And also you may got fibrous dysplasia, which affect too many facial bones, particularly the orbital roof, and it also may affect the bony nasal septum. And fibrous dysplasia indicates expansion of the affected bone and the ground glass density of the bony matrix of the tissue. Then this is a good example of maxillary sinus fibrous dysplasia. The sinus is expanded with ground glass appearance, and this is the 3D reconstructed image showing the expansion of the sinus. Then one of the benign lesions in the sinonasal area is the inverted papilloma, which is a tumor arising within the nasal fossa, and it may extend into the adjacent maxillary sinus. This lesion is particularly inside the nasal fossa, which is expanded, while the anteroquinal polyp will arise primarily in the sinus, and it may extend into the nasal fossa. Then in order to, this is another case of inverted papilloma occupying the left nasal fossa, which is markedly expanding and is encroaching slightly on the drainage of the maxillary sinus where you can see air fluid level. Then this is the difference between anteroquinal polyp and the inverted papilloma. In the anteroquinal polyp, the sinus will be expanded, the ostium will be enlarged, and you got some material in the nasal fossa. But in the inverted papilloma, the main part of the lesion will be seen within the nasal fossa, which is expanded, and some of the lesion may extend in the maxillary sinus, which is not expanded in this case compared to the opposite side. And also, one of the most important findings is to see that the ethmoidal air cells, which are adjacent to the site of the lesion, are opaque, while in the anteroquinal polyp, the ethmoidal air cells are commonly not important. Then this is also a benign lesion which exists in the sinonasal area, which is the nasopharyngeal angiofibroma. And you know that this lesion is particularly occupying part of the nasal cavity and part of the nasopharynx, and it is very vascular and is almost confined to boys. And angiography sometimes is helpful for diagnosis and also for preoperative embolization to decrease the vascularity of the lesion. Then to diagnose sinonasal malignancies, bone destruction is the most important sign. And you see here a mass which is centered in the region of the maxillary sinus, and this mass has destroyed the area totally, extending into the cheek, extending into the infratemporal fossa and in the nasal cavity, as well as in the masticator space. Then this is another example of a sinonasal non-Hodgkin lymphoma, a malignant lesion destroying the bone and extending into the root of the nose, as well as destroying the zygomatic bone as well. Then the CT findings of sinonasal malignancies in general will include a soft tissue mass that is located inside the affected sinus. This mass will show heterogeneous enhancement compared to the mucosa, for example, which will show marginal enhancement. And the most important feature is aggressive bone destruction compared to the regular expansion or the smooth expansion caused by the mucosa. Then you can see here a mass inside the maxillary sinus that has been extended into the cheek, filling the infratemporal fossa, as well as destroying the mandibular ramus as well. This is a maxillary sinus carcinoma, and this is another example of an ethmoidal carcinoma infiltrating the nasal fossa compared to the normal nasal fossa and turbinates on the right side. And because of obstruction of the drainage of the maxillary antra, you can see retained secretions in the maxillary sinuses. And all of you can easily differentiate between the enhancing tumor mass from the retained secretions within the sinuses. Then too many other malignancies can occur in the region of the maxillary and the region of the sinuses, including lymphoma, melanoma, fibrous histiocytoma, fibrosarcoma, osteosarcoma, one of the lesions commonly encountered, and also metastatic deposits. And this is a case of maxillary sinus sarcoma. by MRI before and after contrast injection. You see the tumor mass and you see the extension into the masticator space. And this is the common appearance of the osteosarcoma in the paranasal sinuses infiltrating this area. And you can see the matrix calcification, you can see the tumor mass, you can see the erosions of the bones adjacent to the tumor. And this is another example of osteosarcoma of the maxilla infiltrating the anteromedial aspect of the maxillary sinus, protruding into the nasal fossa, as well as subcutaneously in the cheek, and lower down it infiltrates the alveolar margin as well. Then some of the lesions, neoplastic lesions, may come from adjacent structures, like in this case of an invasive pituitary adenoma. This is a non-invasive pituitary adenoma with clear sphenoid sinus underneath. But here in this patient, you see an invasive pituitary adenoma that has totally infiltrated the sphenoid sinus. And the non-invasive pituitary adenoma will extend in the suprasellar area, while the invasive pituitary adenoma will infiltrate the floor of the cella and invade the sphenoid sinus. And I thank you very much.